Mariko Khan, and I am the Executive Director of Pacific Asian Counseling Services and one of the co-planners of the API presentations that we've had this year. Just by way of introduction, I also serve on the boards of the Asian Pacific Policy and Planning Council, as well as the board of Cambodia Town, Inc. in Long Beach. I am proud of the fact that I serve on a lot of committees and work groups in order to influence policy at the planning stage and to make sure that APIs have a voice. And there are many of us in the audience as I look out who do the same thing, going to meeting after meeting to make sure that our voice is heard. It's my pleasure today to introduce two of my colleagues who will be talking about the challenge of community-defined evidence in our communities. The first is Pisay Sok, and because our time is so limited, I'm not going to spend a lot of time introducing and giving their credentials, because honestly, it's right there in the program, and it's so much better written than my ability to talk. So Pisay is a mental health clinician at Pacific Asian Counseling Services in our Integrated Network for Cambodians, which is a DMH-funded innovation plan. And we are very proud of the fact that it was one of the 4 API communities, along with the Samoan, the Chinese, and the Korean communities, to focus on integrated care for APIs. Pisay is a very unusual, unique kind of guy. We like to tease him as our kind of George Clooney clone because of his gray hair and his handsome, good looks. But he's also got some seriousness to him. So Pisay, if you would like to come up, I believe that Pisay would like to be in the audience so that he can commune with you better. And so I'm going to ask him to go down and take the mic, which is right there in that corridor. Either way. And here's the clicker. And we're going to start off with the Buddhist blessing ceremony. And while he's going down there, I just wanted to say that the Integrated Network for Cambodians was started in the fiscal year 11-12, and it's part of the innovation plan. And we have been very fortunate that we have been able to provide integrated behavioral, substance abuse, and primary care for Cambodians of all ages in the Long Beach area. And we also want to appreciate the fact that DMH funded the innovation plan because we have learned so much about how to outreach and engage our community. And this is one of the practices that we have been using. So, Pisay.
Thank you, Mariko. You know, it's always a pleasure to be in presence of great company. And I feel like, I'm amongst my family, and the head of the house just spoke, and I'm having to, follow that. And so it's, I'm glad to be here. It's been a fun, obviously, morning with everybody. And so I'd like to take the opportunity just to present one of our interventions, as Mariko kind of alluded to. Just to kind of give you a quick background about myself, I grew up in a Buddhist home. My father's a Buddhist minister. The term is acha, so he was that bridge healer. He would be considered a wisdom keeper and ultimately a healer among the community. He was a preserver of tradition and a place where people would come, or a person where people would interact with and draw wisdom from. And so the essence of, all right.
No, I don't know what happened.
Because I saw everybody's face. I read the biofeedback. Everybody's like, what is that? I'm here, so.
Press Alt D.
Well, to the right here is my, no, that's not in. Sorry. Is it okay if I'm down here? Because sometimes being up top I feel like it's from the glory part of the mountain. I feel like I'd rather be down with the people. So, I wish I had a podium.
Does anyone know?
We need the
password.
Is there a password?
Password is lunch.
Oh, lunch.
I'm so sorry. This was not supposed to happen. Okay, let me go next door.
These things happen. Maybe. Oh, God. Okay. So just to kind of, as this is getting fixed. So my father, again, I grew up in this home, and I remember growing up, I was usually sleeping in the living room. We lived in a two-bedroom apartment, and with three brothers. I'm the oldest of three. And I remember every Saturday morning, before I can get up and watch my cartoons, I would get a knock on the door. And all of a sudden, I see people coming in with flowers and gifts, and I'm in my skivvies, because I'm in my underwear or whatever, sleeping. And all of a sudden, these people come in with all these gifts, wanting to see my father. So I was like, what is going on? And my father would set up this little table with different candles and a bowl of water and some things, a little brush to splash water. I didn't know what was going on. I just knew that something was significant. I had to get out, and I needed to get some clothes on, right? And so it's interesting, growing up, I didn't know really what was happening in that very space of my house. And so again, I didn't realize that coming back now, like almost 30 years later, I come back to talk about this very thing that part of my history, my roots. So the objective of my talk this afternoon, is it evening already? This afternoon, is 3 objectives. One is to really talk about what the ceremony entails. I know with 15 minutes we really can't go into details, but what is the ceremony? What is the blessing ceremony? And second of all, how does it meet the needs of our community, and particularly our clients? And third, how can it inform other clinical practice? I know a lot of us are clinicians or involved in mental health, so how does it all, what can we draw from this particular intervention? So let me go ahead and consider the context first of all. What type of community are we dealing with? As we know, the Cambodian people suffered a tragic genocide in the 1970s. And as I previously alluded to, at that time, there was a lot of trauma. And as a result, as we all are mental health people here, we realized that there's a lot of things that emerged out of that. And the thing that came up this morning that was very significant, that tied it all for me, was that as a result of that, everything got reversed. Starting with the year 0, what I alluded to, all of a sudden what was traditionally valuable, significant, and important got thrown out. And so at that time, what happened then is a community that was being disoriented and again, confused as to how do we maintain a system or a tradition to go forward. And so again, on top of these symptoms here, really at the harder issue was a people trying to find an identity or reestablishing a new identity. So again, genocide created that. Also, there were refugees, meaning they were displaced from the very source of their identity, their land. And so the difference between refugees and immigrants here, I just want to make a distinction. Refugees are those who were displaced because they had to for the sake of survival, right? Whereas immigrants, they had a choice to go where they wanted to go or to immigrate to, generally speaking. That's the difference. And there are different waves of Cambodians that came to the States or to Long Beach and other parts of the world as refugees, sponsored by different parts of other governments throughout the world. And so, again, make a distinction, because those who experienced refugees and those who came later as immigrants, they have a different story. Even though they both went through genocide, there's a nuance. With that, you realize there's language barrier issues, right? Culture issues. All of a sudden, those who were the elders in the community, who were the wisdom keepers, eventually found themselves having a place where they have to rely on their children. I was a cultural broker for my family. Hey, can you read this? Can you talk to this? Can you make a phone call? Can you call this place? And I grew up in that environment, always having to be that cultural broker. All of a sudden, my parents had to rely on me to be the source of wisdom and power around to navigate this new environment. Again, you see all the different things: unemployment, low SES, and lack of medical insurance and so forth. These are just symptoms of a deeper issue of imbalance that's happening in our community. And then there's also an aspect of worldview, right? So in the Cambodian people is a mixture of different worldviews, from animism, which is the idea of their spiritual realm. There's a spiritual transcendent reality that exists. And furthermore, with that, there's also this aspect of Brahmanism, right? This priestly idea, this priestly culture that emerges from India that kind of take root in Cambodia. My father would do these chants. I remember when I was growing up, I broke my arm, okay? I broke my arm, and one of the things that he did was he made this bamboo brace. And I was confused. So instead of taking medication, he would do this chant in the Pali language. He would chant, and then he would take this water and he would spit it. I'm thinking to myself, I might get an infection from that, right? And I'm like, I'm not sure what's going on here. Why are you spitting on, in my mind, why are you spitting in my broken arm? But there was something almost mystical about this reality that was happening. I didn't realize at the time. And eventually, obviously, my arm got better, but I didn't appreciate what was going on at that moment, what my father was preserving, and this was part of the Brahmin tradition. Weaved in with that is also the aspect of the Buddhist worldview, right? Which, again, comes with its nuances, which I'll talk a little bit more in a moment. The aspect of karma, reincarnation, and different aspects of that nature. But also, you'll have, one thing I didn't mention is also you have Chinese folk religion as well. Because Cambodia is a very unique plot of land that converges with so many cultures. And so as a result, you also have ancestor veneration as a part of it, right? So part of it is also honoring your ancestors. So keep that in the back of your mind. People who are ultimately already thinking about a transcendent reality. So you can't just talk about wholeness and healing just with giving a medication. There has to be some spitting going on and things going on of that nature, right? Right, that's what I'm talking about. So with that, just kind of the brief law of karma, this is kind of the fundamental aspect of how they understand the aspect of justice, as law of cause and effect. So that if someone were to be kind of having a bad day or having a life that was not going the way they anticipated, they would say, okay, there has to be something going on that was probably this whole aspect of this generational component, right? Do you remember they were talking today that this is generational pain that was getting passed on from some previous generation. And so with this idea, this karmic idea, a lot of our clients view their symptom as, there has to be something that I did. That's why my kids are like this way. That's why I'm in this situation. So they're trying to find the answer as to what it is that's causing them to be sick or to be ill or to be disenfranchised, whatever it is. And it goes back to that kind of understanding. But a lot of times now karma is not a bad thing. It's good or bad, right? So a lot of times we focus on the negative aspect of karma. They'll say, oh, there must be some reason why this is happening. I got to figure that reason out. Or sometimes we'll say, you know what, I just got to pay out my karma. This is just the way it is. I'll live it out now. So you kind of have that attitude going on. And then in the mix of that, you also have astrology. So when a problem goes on, you have to figure out what the answer is, right? A lot of times people go to faith healers or fortune tellers or my father, the Achai, and talk about, can you figure out something with the stars or my number or something? Can you figure out what's going on? This is not actually Buddhism per se, but it's also the cultural religion that's there. So they're going to find people who can read fortune, palms. And this is what happened in my house because my father was a teacher. So people would come and he would read palms. He would do different healing services, ceremonies. And I saw this is there. And also this aspect of numerology, that there's some aspect in which our number, when we're born, it all coincides with how our life has emerged. So understanding these components is very essential as we are going to serve this community, right? In addition to the trauma, you can imagine people are trying to find answers. Why did this happen to us? Why? Isn't that the first question we ask when we are dealing with suffering? Why? And how do we deal with it? So again, that's the context. And so as we move forward, then what really is the aspect of our community? First of all is the aspect of the temple. Remember, when people came here, the part of the Cambodian community was grounded in Buddhism. So the temple is not just simply a place of worship or a place where people go, though it's that, but it's also a place where one can preserve cultural customs, where the language is preserved, where the community gathers. It's a center and a space that is sacred. Why do we have the blessing ceremony not at the mountaintop, as great as it is? How about the beach? Because the moment you walk into this space, you take off your shoes, you bow a little bit lower than normal, right? You're greeting everybody. And then in that space, you see this magnificent array of aesthetics. You'll see the different pictures, statues, that are drawing upon all the senses. You'll hear the music playing in the background. You'll smell the burning of incense. You will see the lighting of candles. So there's a space that is significant, and the posture with which you enter that space is also significant, which reminds me of a story. There was a Westerner that went into a temple, and he, wanted to see what was going on, what was going on with this place. He thought it was cool. So he walked in there, and he tried to take off his shoes, and the monk was like, can you take off your shoes, please? Because, this is a holy place. He's like, oh, okay, fine, I'll take it off. He takes off his shoes. And then he's like sitting around, and then he's laying out with his feet, right, to the monk. Oh, I'm so tired. Oh, the monk says, sorry, can you put your feet back? Because usually you don't want to show the bottom of your feet. It's very disrespectful. The guy goes, what's the matter? It's just the feet. The monk goes, okay. The guy goes, what's the matter? It's just a finger. But the reality is there's something about posture, communication, body language that is significant in the Cambodian community, with which that if we're not able to navigate that, will create, as you guys know, you've dealt with cultural competency, this is an issue. So again, the temple is that space as you walk in is significant. And then you have the monks. The monks are the preservers, and these are the ones who actually observe the teachings of the Buddha, right? There's 3 gems that we talk about in the Buddhist tradition. The Buddha, the Dhamma, and the Sangha, right? And the closest association would be this. They use this analogy sometimes that when you have a symptom, you go to the doctor finds a solution, has a prescription he gives to you, and then in taking the prescription, you actually hopefully will get healed. The Buddha, in one sense, could be the doctor. He found the problem to human suffering, and he's captured it in his prescription, the Dhamma. So long as you're prescribing and observing the Dhamma, that's where healing could happen. And the Sangha, the community, ultimately becomes the people who are like the nurses that tells us, hey, I think it's time for you to go back and take the prescription again. They remind us. So the monks are one aspect trying to observe the tradition of the Buddha embodied in the present moment. So the Buddha's not dead per se, he's present in this people. Furthermore, then you have the Acha, and that's wrong, by the way, gentleman right there. And the Acha, like my father, is the bridge. It's the bridge between the monks and the temple, who at one point was a monk himself, eventually becomes more of a lay person as a guide. He said, hey, you know what, let's go see the doctor again. And so ultimately you have that, and then you have the community. Do you see then all of a sudden this blessing ceremony is not just about this chanting, though it's touching that aspect of their karmic idea, but there's also this space that's a place of preserving culture, language, connectedness, restoring a sense of balance. Because at first, when our community is going to get healing, all of a sudden they're disoriented because the world around them, they've lost that sense of power, their wisdom. So to be old is to be useless, have no significance, discarded. So then all of a sudden, this place is a restorative aspect in restoring that, where eldership, wisdom, guidance is significant. And again, and part of that also is that aspect of community, which we've been talking about all this morning. That community is so significant. And so again, so the blessing ceremony then has these elements, which I wish I had more time. I am so sorry. So it's offering of incense, lighting candles, and flowers. These are symbolic gestures. When the people come in, they give flowers, incense. Flowers, a symbol of purity of mind. Incense as a prayer, and candle of wisdom, given as an offering in preparation to receive this blessing. And then prayer of invocation is to invite all the angels, the spirits of the universe that are good energy into the space. And then you have the triple gem, the Buddha, the Dharma, the Sangha, the 5 precepts of observing. And then you have the blessing of the monks who will eventually use these elements of water, the candle that's dripping into this bowl, and eventually they will splash it, sprinkle it on the community. And in doing so, it's as a symbol of water, it's the source with which everything can be absorbed. Bad karma, good karma, everything. So when you're sprinkling it, it's washing away, it's purifying, it's restoring. It's that symbol of all those elements of the flower and the candle all in the mixture and symbolically, as well as not just symbolically, but I think reality. Something's happening. And then lastly, there's a prayer of dedication to our ancestors, because remember the need early on of our community is that a connectedness to our ancestors. And so therefore, part of that last aspect of the blessing ceremony is also praying for our ancestors who came before us, and also for other creatures and things in the universe that are also in need of releasing from suffering. So in that way, it's a holistic approach to wholeness and to health. It's not just me being blessed, but I'm also wanting to be a blessing to others. So again, just with regards to the outcomes, we gave some pre and post surveys, and one of the things that had happened, as you can see here, was the expectation. So some of the questions is, I think this will help me feel physically better. I think this will help me sleep better. I think this will help me have a better appetite, and I think this will help me be supportive, so on and so forth. And the majority of people going to this ceremony has an overwhelming yes, the blue, right? And so we would imagine that after the ceremony, it would correspond to that, so that they would receive what they actually expected. And as you see, it's right. When people came, we gave a post survey. This is exactly what corresponded. I found the service very helpful. Bam, across the board. Oops, sorry. Yes. I feel the same. No changes or improvement. No, it's obviously no. I feel more comfortable around other people. Bam. You see that? All those different things are indicators that something is working. It's not reinventing the wheel. It's always been there. Even if DMH would be gone tomorrow, God forbid, because we'd be out of a job, but the reality is this community would still have a place of healing. And I want to close it all tied together with this last thought here. I know there's a lot of thought, but let me just tie it all together. One of my favorite movies of all time comes from a scene in Enter the Dragon by Bruce Lee. And in this scene, Bruce Lee is training a young apprentice. And so Bruce Lee, he walks up, and the young guy's coming, Bruce Lee says, "Kick me." The guy was like, "Oh, okay." Bruce Lee, in his kind of stoic way, "What was that? We need emotional content. Now try it again." That guy's kicking him. "I said emotional content, not anger. Now try it again with me." You know, the Bruce Lee way of saying it. How did that feel? That's it. And the student was like, "Let me think." And Bruce Lee was like, "Don't think, feel." It's like a finger pointing away to the moon. And then the guy's looking at his finger. "Don't concentrate on the finger or you'll miss all the heavenly glory. Do you understand?" He bows. "Don't take your eyes off your opponent even when you bow," right? That's the whole scene. And the point that we're trying to talk about is this. This is me tied all together. I didn't have a lot of time to describe the blessing ceremony, but I wanted to point something out, that the blessing ceremony is just the finger. It points to something much more rich, a deeper reality, with which they draw upon the Buddhist tradition. It's pointing to something much more deeper within the Cambodian community. So in essence, the context is the key that unlocks the gateway to us to draw upon the wisdom of the past to guide us in solving the problems of our present. And furthermore, the ceremony points to something much deeper for our clients. It awakens them to the reality that they're not just simply paying back their karma, but it's an opportunity to create new ones forward. So in doing so, it can be a blessing not simply to end their own suffering, so that when they are restored, they can be a blessing to their family, to their community, to their city, and ultimately to their world. So I'll leave with you. Don't concentrate on the finger.
Thank you so much, Pisay, and I think you get a flavor of the kind of work that we are doing in the INC program to combine non-traditional practices, which really in our culture mean the traditional healing practices, to work in a Western model of mental health services. Now it's my great pleasure to introduce a dear friend of mine who is really very well known in the API community, particularly in mental health services, but also because he is so well regarded in terms of the research that he does. And he's going to talk about several CDEs that have gone through the system and what the process was like. And because I'm technologically challenged, I will try to figure out where his PowerPoint is, but he thinks he knows how to do it, so I leave it to better hands. I'm sorry, his name is Terry Gogg. Duh. He knows me well.
Just before the session began, Pisay said that it's scary to talk in front of your family, and I think besides that, I think it's more scary for me to talk between my family and lunch. So I'll try to be brief as well as hopefully informative. I'm going to hopefully we'll shift the mindset. We have talked a lot this morning about community-defined programs, and many words of wisdom were said. And I think that what I'm going to do is to not share with you, how the process, really how the process of making it into community-defined evidence programs, but some of the lessons that I've learned during that process, and for you to hopefully something of use to you as we go through this process. I think that what we're talking about in terms of community-defined practices this morning is those, as has been, I think it is Wade Nobles who call them history of practices. That is the wisdom from the community. What I see as the CDE or community-defined evidence practice is really trying to articulate what is helpful for our brothers and sisters, for our parents and mothers, and our family members with mental illness, substance abuse, and other behavioral health problems. And in that sense, I think evidence-based practice and community-defined evidence programs are really not two different entities. It is more of a progression. So let me start by unpacking a little bit of those two domains in a way. Evidence-based practice has been defined more as an integration of best available research with clinic, but it has to be tied in with clinical evidence as well as in the context of the client's characteristics, culture, and preferences. Isn't that what we have been talking about in many ways? And if we have to unpack what is community-defined evidence practice, and this is from Ken Martinez's work, you could see that I try to unpack it by highlighting the words, but you could see that the emphasis is on what the community has experienced as helpful, and there is. And as it says here, may not have been measured empirically, but that has, we have talked about this morning, the whole morning has been practices that have been accepted by the communities, that have values in the communities. And my struggle, Western trained, but I know that a lot of things that we do are helpful. The struggle and the challenge for how many years I've been working is to make it show. So at the Asian Pacific Family Center, we have been, one way that we have been doing it is through some of the federal demonstration grants. We have been very fortunate to have been awarded 11 grants. Part of the nice things about it is that they have a lot more money set aside with each of the grants for program evaluation. So we have been able to move that level of evidence forward. And so these are some of the programs that we have been working on or have worked. And out of that, that's where we have been able to submit and got acknowledged for out of the 22 at that time of community-defined evidence programs by CIMH, 5 of them were these programs that started from there. But during that process and going through that and going through all this time, and we're still doing some of the work, I have thought, we have gone through a few learning experiences, and I'm trying to summarize them for you here. I think in order to embark on this process, we have to assess our own readiness. So I'm asking you now to think about where you are, what you do, your agency, your community, and to look, and so I would talk a little bit about both the organizationally, our staff, and our program readiness. The organizational readiness, to me, in doing each of these programs, I know that is more than what the money that has been given us by either the federal, county, and state resources. A lot of times, my boss, when I try to do one of these programs, she would say, "How much are we losing this time?" Because we have to put in a lot more. Indirect cost is not what really our indirect cost is, for example, so it has to come from somewhere. Are we willing to put those resources in? Learning culture. We, as providers, I think someone said this morning, I think it was Gigi who posed this struggle and this challenge, I think, very succinctly. If we have that much money, and if this, are we going to serve people? Are we going to wait and ask for our evaluation to come in before we could serve these people? How does the agency itself value, support learning? By this, I don't think that it's a forced choice here. What I'm only talking about is that, are we willing to say, let's think about, let's be willing to learn here, how can we do it better? And it has to be infused more than just with our staff, but how the structure of the organization let us do that. In terms of staff readiness, very quickly, service versus science is one of the things that we have been talking about all day long. You know, our staffs are there to provide services. They want to serve the community. And science evaluation is not part of the culture of service. And how asking them to do in LA DMH, some of you may know OMA, how difficult it is to just get those DOMAs in. That is the beginning of program evaluation. That is really basic, very rudimentary. Well, so if you want to move the level of evidence up, that's a lot more. Those in innovation, ISM, you know about it. There are ways of doing it. But my point here is that we are always struggle between these two, evaluation and science. Fidelity versus flexibility, that's all we have been talking about. With the EBPs, that's the issue, is that when fidelity trumps flexibility, it becomes untenable, especially for many of our communities and the programs that we do. Not to trash mental health first aid more. Just give you a little story. One of my staff, a Latina staff, going through mental health first aid, had to do this practice in front of the trainer. And she wanted to say one sentence in a different way because she thought that would be more understandable to the audiences that she would be working with. And she was told, no, you have to say it exactly like this. Practically, you have to breathe right here. So that kind of fidelity expectations makes it so difficult for us to, in our communities, to know what would work. Go back to evidence-based practice, the definition of it, you got to, it's not just about research-based practice. It's research-based practice plus clinical skills and acumen, plus clients' culture and preferences and who they are. And when Dennis talked about, well, you know, I think it wasn't Dennis. Someone said, well, we have EBP has been sold to our profession, and I think it is that very myopic EBP that has been sold to our profession, not EBP. So we have to be able to say evidence-based practice is not this fidelity-driven, manualized practice without regard to what we know as workable and what the client's culture and everything else would calls us to do. So program readiness. This is the part where with all of that, we have been able to, we have to address, when we went through the CIMH process and other processes, if you boil down the questions that they ask you to address, it's these three things: theories of change, cultural relevance, and evidence of effectiveness. Now, theories of change. I think this morning, per se, right now, just before me, and the two sessions this morning had already articulated a lot of the theories of change. It is not just Bandura's social learning theory or Prochaska stages of change are the theories of change. It's just identifying what is, how does change happen? Why is this blessing ceremony change something? in the way that we think it is. And thinking about it, a quick story, and I know Gladys has heard this one from me. There was a Buddhist monk who went into a Zen pizza parlor.
A Zen pizza?
He looked at the menu and asked the owner, "I want one with everything." And the owner said, "Okay." And when the monk gives her the money, she puts it in her pocket. And the monk said, "Where's my change?" And the owner said, "Change must come from within." Yes, change must come from within. Feel. However, we have to articulate from without. What is this change about? Where does this come from? Cultural relevance is, again, it is really not hard for many of us to articulate why our programs are culturally relevant and to the populations that we serve. And evidence of effectiveness, and this is the part where I like to share with you. The levels of evidence that's why the EBPs and CDEs are not really so distinct. Is that because it is just a continuum of level of evidence, and in the API community, through the community the Reducing California Reducing Disparity Project, the API report has, I think, 52 to 54 promising programs and strategy that are identified in that report, and I see that as really, some of them are from very rigorous program evaluation. So it's like some of those that we have in the CDEs that are my agency has been able to produce. Some of them are very little evidence. There's community consensus. Some of what they say presented is evidence. It's just where it lands. And it starts from somewhere, and you move them along. And at each stage, it is harder and harder. I could tell you, I'm doing a randomized clinical control trial right now on one of the programs. I thought I was pretty clear about what we were doing. But with a good program evaluator who put me through the ringer, we have we were able to, and work with us in terms of the evaluation tool. I always knew that it would work. I have because it was consistent with the community values and so on. But we're still doing some data analysis, so I don't want to jinx it. But so far, it looks really, really good, because we are trying to combine some of these elements. And one of the things that we have decided to do, instead of manualize the program, so that you have to breathe right here at this break of the sentence, like some other programs, we have decided to provide like objectives. Here are the session objectives, for example. And here are some ways that you could think about how you could do it with the population you're serving. And so what we are providing is guidance versus mandate. And in many ways, the emphasis on many of our CDEs and submissions, we focused so much on the evidence of effectiveness. Actually, to me, that's not really the issue. And when I talked to CIMH, they also said that of all the programs that were submitted, the largest number of them that were not able to be for them to support as a CDE is not evidence of effectiveness. It is more about the theories of change and cultural relevance that are not well articulated. So I'm hoping that, as we go forward in terms of what you want to, what you see as what the community needs, and know that it works, articulate those why it works and how it is relevant to our community. And in many ways, evidence will follow.
Huh?
Thank you.
Thank you, Terry. So while Terry is trying to find my my PowerPoint, I am aware of the passing of time, and I'm going to ask you to make a sacrifice of a few more minutes. I really felt it was important to give both Pisay and Terry the opportunity to more fully flesh out their presentation. So rather than go through my PowerPoint, what I'd like to tell you is that they are available, as are Pisay's and Terry's, online. And I would encourage you to go online and look for them. Now let me switch. What I was going to do was to sort of use our blessing ceremony as a test model for the CDE application. But I think Terry did such a good job of pointing out the different areas that you need to cover that I would like instead just to say that when we looked at our ISM, we really feel the use of in quotes, non-traditional practices are something that we can turn into a CDE model that can be used in a locally, in a locale, which is Long Beach, with a specific culturally relevant group, which is the Cambodian community. And what we need to do is, of course, flesh it out and develop all the levels of evidence. I think because Buddhism is widespread in many of our Asian cultures, that what we set up might then be used as a replicable model for other communities, such as the Thai community, which also are very strongly infused with the Buddhism. So with that in mind, I'm just going to kind of skip through all the PowerPoint. I did put up all the PEI priority populations and the questions that must be answered. But the last page has references, and I do want to point you to the article by Martinez, Calles, and Hernandez on CDEs and that approach, as well as the application guidelines. What I'd like to finish with in terms of my own presentation is just to repeat what Pisay said, if I can find my piece of paper, because I think what he pointed out is that when we think of traditional healing practices, we have to look at the whole. And in reality, the blessing ceremony is giving the client the opportunity to create a future. And when you give people a future, they have hope. They are going to feel better. They are going to reach a state of wellness. So this ceremony is so important because it's woven into the cultural fabric of this community. You cannot separate it out. What I particularly liked about Pisay's analysis is that not only is the client empowered, but they are alleviating not only their personal suffering, but in taking part in the ceremony, they are actually doing good to others, for others. And that is something that so many of our ethnic communities have in our spiritual practices. And I think it's something that needs to continue to be defined and presented as community-defined evidence practices. So that's going to be my presentation. I don't need any applause. But I would like to give folks a chance, a few minutes, to ask questions or to make comments. The microphone is there, or is it?
It's right there, right above the
okay.
projector.
If anybody would like to ask a question of my colleagues or to just reflect on what we've been presenting, I would be so honored by that. So is there anyone? Don't be Asian. Yes. Do you mind coming up to the mic? Only because it makes it easier to hear. And I don't know, is the mic on?
Oh, you have to turn that on, yeah.
You have to just turn it on.
I turned it off, sorry.
Is there a button?
There it goes. So I just wanted to make a comment about adherence to fidelity that you had talked about. And I agree that adherence to fidelity and not being able to change a sentence to make sense, to accommodate, any part of an audience that you're talking to is sort of ridiculous. But I think it's important to talk about fidelity to the theory of change. Because if you have a theory of change and you're not following that theory of change with fidelity, then what's the point of the practice? Does that make sense?
I'm going to turn to my colleague,
Oh,
Terry.
Yeah, no, I agree. Yes, if you're thinking, but how do you make sure that your fidelity of change is your fidelity is consistent with your theory of change is in your program?
Right.
In what you do, and if you say this is what, based on that theory of change, this is what we do.
Right.
But you're doing something else. That's a very different thing. However, yes, the flexibility needs to be there. I've seen a lot of work on adaptation, so it's not like that you cannot adapt things. Besides, the reality is that nobody with an EBP under the name could tell you what is exactly working. If I cut out session 3, would that work just as well? Nobody can
only
tell
if you measure it.
Yes, and so it is really, but then it needs to be. This is the objective of this program, or this session. Did you do that?
And then the clinician is free to follow that theory of change as it matches to the family or the client that they're working with.
Exactly. We have to hop on those two other aspects of what is evidence-based practice.
Great.
Yes. Any other comments? Is it because lunch is just around the corner? Yes, Dr. Chapter. Oh, and Emily. So if we could have Emily speak first and then Dr. Chapter.
Oh, wow. It's getting real.
Hi, everyone. My name is Emily Wu Trong. I like to call myself a community activist for mental health awareness because the stigma is way too strong in our communities. I am a person of lived experience, and I have been sharing my story of recovery and empowerment because there are too many suffering in silence. And so I've come out since July 2013, and I said, I will not end my life because I have a story to share.
Right.
There is no shame. There is no shame. The more we talk about this, the more we will alleviate this stigma. And so I agree about, when Terry Gaka started his presentation on just how do we even get how do we get the services to the people who need it so they don't feel that shame to be able to ask? And yesterday I went to the LA County Department of Mental Health and Spirituality Conference, and I made a comment and I said, we need to get rid of the competition and the competitive cultural nature of our culture and be able to let down our guard and say, it's okay to ask for help. And that way we can, I believe the mental health movement is a love revolution. To be able to cultivate a culture of compassion, passion, love, caring for one another so that we don't have to feel scared to say we need help. So thank you so much for having, the seminar, and I'm enjoying myself.
Thank you, Emily.
Hi, I actually have a question for both of you. Much of medical research in the last few years have been concentrating on the differences between effectiveness and efficacy. And so a tool, a pill, or a medical device might be effective, but if it doesn't have cultural relevancy to a target population, then it's not efficacious. So I'm wondering, in our process of evaluating behavioral practices, behavioral science, is that something that you would think about considering? Because I haven't seen much about the advocacy of a practice in the community.
Actually, I wanted to take one hit at that, and that is in our INC program, one of the things that we're doing is not only measuring the pre and post surveys of how these particular healing practices, we are asking our partners who are community-based organizations who are doing wonderful outreach and engagement to also give us information on each person in terms of how else they were helped. Because I think we are making a change in our community when we provide housing linkages, when we give them information on where to get food, shelter, clothing. So I think the impact of a program like this is well beyond just what is actually happening in the billed services. And that is where I think we're going to have the greatest efficacy, if we can change our community from the ground up. And I really appreciate all the staff who work on this because they are so dedicated.
I would say that within our community, within our integrated program, we also have, we partner with our children's clinic, the TCC, so there's also that component where science and efficacy is measured in terms of clients who come into our program have to have, or for the criteria is an Axis 1 diagnoses, some medical condition, chronic medical illness of some sort, via B, hypertension, diabetes, cholesterol, high cholesterol, so on and so forth. And then either or that a substance abuse. And so I think with that, we already have those measures in place as well integrated into that. I'm not sure if that's the answer to your question.
I actually do not disagree, but I actually thinking about more how we present the evidence to the Mass General. Right?
Oh, I see.
And the language that we use. And we can do all of this, but if we don't follow and use the right language for funder, for policymakers, then we're missing that bridge. So that's what.
I think you're right. I think that there, with this being said, because I just to kind of talk about in a general sense, having language, having cultural interpreters is significant, whether that be in a spiritual community, as well as a mental health community or policy. I think having cultural, again, brokers that can navigate both aspects to advocate, because I grew up in the religious community, so I do have the way of, I understand the language, I understand what they talk about when they refer to healing or blessing. There's assumptions that come with that, and I think having some peoples or groups of people that are well aware of what is being used and I think the power behind it. I think, like I talked about before, the finger, right? Like when that person just gave you, they have to know what that means. And I think someone that can navigate both spheres is significant. And I think that's what's hard to find, is being able to know the ground level. How do you actually implement this at the clinical level and then at the policy level? We have to have people that understand both dimensions. I think you're right.
And I just want to add the other thing that we are learning from our ISM projects is the real necessity for us as community to write our own papers and to document what we are doing, because DMH is looking at outcomes, and rightly so, but the outcomes they are measuring are outcomes that have to do with patient recovery in a very narrow way. And one of the things I'm learning from the Latino ISMs is that clients actually will say, I feel better just because I had my intake. That doesn't fit into the outcome model, does it? So we have to gather our own evidence and publish it.
And that's the efficacy.
Okay.
Yeah, I think,
all right.
I think you're,
So, thank you so much. Thank you. And I want to thank both